The first article is looking at this title. Basically, it was evaluating the biological differences of 3-paclitaxel and sirolimus-coated balloons on coronary lesions in a rabbit model. It came from Japan. Basically, the background is what they were talking is that RCTs comparing various drug-coated balloon technologies are sparse. The aims of the study was to histologically and biologically compare the drug effects and the safety of a low-dose paclitaxel-coated drug-coated balloon, a regular dose PCB, that is again paclitaxel-coated balloon, and a sirolimus-coated balloon, drug-coated balloon, that is SCB, which was called Magic Touch. The DCBs were inflated in healthy iliac arteries of 18 rabbits, which were euthanized after 28 days. The treated iliac arteries and distal skeletal muscles were histopathologically evaluated and drug concentrations were measured. And the findings is what threw up interesting observations. In terms of the characteristics of the DCB, as I mentioned, there were 3 separate DCBs which were being used from 3 separate companies. Having paclitaxel as a low dose, paclitaxel as regular dose, and sirolimus as is shown on this slide. The drug dosage is mentioned 2.0 drug dose microgram per millimeter square, 3 microgram per millimeter square, and 1.25 microgram per millimeter square. These were the formulations. I will just leave the slide for you to understand the context of what we're talking about, as well as the excipients. Now, pathological analysis of the treating arteries and distal skeletal muscles is what was done in terms of the different criteria which have been mentioned on the left. With what agent, with what sequent, magic touch, etc. Now, what was found is that the treated lesion of the iliac arteries drug concentrations were comparable among the 3 coated balloons, the 3 drug coated balloons. The skeletal muscles which were distal to the treated vessel, drug concentrations were comparable in the 2 paclitaxel coated balloons, that is the low strength and the high strength. The muscle by artery ratio of drug concentrations was the highest in Magic Touch, followed by sequent, please, Neo, and agent. And these are the pictures of the treated lesions after the drug-coated balloon use. So as I said, the 3 separate is what can be seen as pictures A, B, and C. The muscle by artery ratio of drug concentrations was the highest with the Magic Touch SCB, followed by the sequent, please, Neo, and agent. High risk of distal emboli with the Magic Touch SCB as compared to the paclitaxel coated balloons. So the basic findings from the study, this was the first animal study to compare the drug efficacy of the currently available drug-coated balloons for coronary arteries. Drug concentration and pathologically evaluated drug effect of the treated lesion were comparable in the 2 paclitaxel coated balloons. Drug effect of the paclitaxel coated balloons was distributed more circumferentially and deeply than that of the Magic Touch sirolimus coated balloon. The drug concentrations in the distal skeletal muscles were comparable between the agent and sequent, please Neo, I'm sorry for that. Muscle by artery ratio of the drug concentration was significantly higher in the Magic Touch sirolimus coated balloon than in the 2 pacrolimus coated balloons. The percentage stenosis tended to be higher in the Magic Touch, again sirolimus coated balloon, as compared to the PCBs. The proteoglycan score also was higher in the PCBs than in the Magic Touch sirolimus coated balloon. So what is the impact on clinical practice which the journal states about? It says that paclitaxel coated, drug coated balloons might have a higher efficacy and lower drug concentrations in the distal skeletal muscles than the sirolimus coated, drug coated balloon. The efficacy of the agent, low dose paclitaxel coated, drug coated balloon, and the sequent, please Neo, regular dose paclitaxel coated, drug coated balloon was comparable despite the difference. So despite the difference in terms of the doses, it was comparable. So finally, the article really says that it is more important about the integrity of the drug coating of the drug coated balloon rather than the drug itself. So whether whatever strength it was comparable is what the article says. So that was the impact on daily practice. That was about the first article. We will, of course, have a detailed clinically relevant discussion on this. The next article is talking about a systematic algorithm which was utilized in an observational scenario for large bore arterial access closure after TAVI, the TAVI multi-close study. Now, the background of this was, although TAVI is a routine procedure, access site bleeding and vascular complications still are a concern, which contribute to procedure-related morbidity and mortality happening with TAVI. So the aim of this study was basically to assess the safety and the efficacy of a new vascular closure algorithm for percutaneous large bore arterial access closure following transfemoral TAVI. So it was consecutively done. It was done in Europe. It was done in two places in Europe. And this was the algorithm which it talks about, which was utilized. So that is the algorithm, the multi-close algorithm for vascular access closure, an echo-guided arterial puncture followed by fluoroscopic storage of needle position, which is seen on the image on the right, and or measuring the skin to arteriotomy distance with angioseal sheath, pre-closure with single or double proglide or prostyle, then the TAVI procedure, then remove the large bore introducer sheath and maintain vascular access with 0.035 stiff guide wire, then advance proglide or prostyle knots, then insert 6 FR or 8 FR sheath, and further course of action will depend upon whether there is an overt bleeding or not. If there is an overt bleeding, there is a clear answer to use 18 FR Manta. If there is no overt bleeding, then it can be a contrast angiography of 5 ml via 6 FR or 8 FR sheath, and contrast extravasation will define the further course of action as is shown over here. So use of the Manta vascular closure device in the multi-close algorithm, there are basically two techniques which are defined in the article. The technique A talks about the methodology being used in case the skin to artery distance is unknown. So the step one would be to review the fluoroscopically stored image of the needle puncture site about the femur head at the start of the TAVI procedure. Step two, to insert the Manta sheath over the stiff guide wire and partially retract the dilator to permit fluoroscopic visualization of the distal edge of Manta sheath. Position the distal edge of the Manta sheath 2 centimeters cranial to the puncture site. Note the Manta deployment depth in centimeters at the skin level. Finally, fully reinsert the dilator and advance the Manta sheath. The step 3 would be to remove the dilator, introduce the collagen plug, retract the Manta device to the deployment depth determined in step 2, mentioned earlier, expose the anchor by rotating the deployment lever, and deploy the Manta device as usual. As I mentioned, this was the technique A, which was to be used in case the skin to artery distance was unknown. And this is what is shown in the picture as step 1, 2, and 3. Step 1, talking about the technique A by fluoroscopic storage of needle position immediately after artery puncture. So step 1, identifying the arterial puncture site. Step 2, positioning the Manta sheath 2 centimeters above the puncture site. Step 3, before deploying the Manta to confirm the lock corresponds with the puncture site. So this is depicted on the article elaborately in terms of this picture. The technique B, this methodology is talking about, it can be used when the operator is certain of using an angioseal device for final vascular closure. Using the letters on the angioseal sheath, the operator can measure the skin to artery distance. The Manta deployment depth is between plus 1.5 and 2 centimeters in comparison to the measured skin to artery distance. And that is the picture which is talking about, as I said, the letters. So this is the technique B, by measuring the skin to artery distance using the angioseal sheath, because the operator is aware of using, is confident of using the angioseal sheath after arterial puncture. So this was technique B. This was the multi-close algorithm, as I mentioned, and this is what happened. So the primary access pre-closure followed by the TAVI procedure in a total of 630 patients. As I mentioned, this was an observational study looking at this algorithm. So the total number of patients involved was 630. And there was remove large bore introducer sheath and maintain stiff 0.035 wire, advance proglide or prostyle, insert 6 FR or 8 FR sheath. If there is overt bleeding, there was a different pattern, as I mentioned earlier. And with contrast angiography, with contrast extravasation, there was a different pattern in terms of managing the particular case. And that was the top level results, which the article concluded. Totally 630 patients who underwent TF-TAVI utilizing the multi-close algorithm. As I said, 630 was the number of patients. Complete arterial hemostasis was achieved in 616 patients out of these 630 patients. VCD failure occurred in 14 patients. Vascular closure approach resulted in a minor and major vascular complication rate of 2.2% and 0.6% respectively. At 30 days, only one new minor vascular complication to the tune of 0.2% was noted. In hospital and 30 days, all-cause mortality rates were 0.2% and 1% respectively. So the article concludes something about the impact on daily practice. What can be the impact? The vascular complications after large bore transfemoral access in transcatheter artery, that is TAVI, in TAVI, are associated with significant morbidity and mortality. It's known. This novel stepwise multi-close vascular closure algorithm involves the reinsertion of 6 to 8 FR sheath following an initial closure with 1 or 2 suture-based vascular closure devices. This provides the opportunity to perform a quick and easy angiographic control and tailor the final vascular closure with either an additional suture or plug-based VCD or neither of these. Use of the multi-close algorithm was demonstrated to contribute an easy, safe, efficacious, and durable vascular closure after transfemoral TAVI with multiple levels of safety nets, resulting in a major vascular complication rate of less than 1%. That was about the initial context about the two studies which we'll be discussing today. I will now request our moderator, Dr. Anil Dhal, to start off the discussion. I have a question for Dr. Anil Dhal. So, sir, may I please start?
Yeah, please.
Thank you, sir. So the first question talks about the practical implication. What is the practical implication of paclitaxel versus sirolimus? Low dose paclitaxel versus regular dose paclitaxel. Is there an implication? Sir, your answers, please.
So, firstly, before we start, I must compliment Dilip and the Ajanta Pharma team for having put this, getting us all together and for putting this all into motion. The pedagogy was quite unclear to me till 3 days ago, and there were a lot of challenges. And it is also auspicious that it happens to be on Shubha Navavarsho, and it is also Dilip's birthday. So, wishing Dilip many, many happy returns of the day. We thought that these are two very interesting papers which have been discussed. One comes from the realm of our getting confused with what is available in practice and how do we use it. And drug-coated balloons are something which may be looking at us as a holy grail, making a comeback. The concept is not new. The concept goes back to 1990s when people thought that they would use the different lipophilic and hydrophobic and lipophilic properties of cytostatic or cytocidal agents, which can then be used to prevent restenosis. So we all know that the journey in drug-eluting stents, by and large, used two kind of group of drugs, the Taxol analogs and the Limus analogs. And really, there was a time that they were neck and neck. I remember about 20 years ago, it was just Cypher, then it became Cypher versus Taxus. And there appeared to be a time when Taxus would kind of do very well. But over a period of time, we have realized that Limus analogs have quite outscored the Taxol analogs. Now, there have been a variety of reasons for this. And we must look at that very carefully because it has implications in the drug-coated balloon space. Number one, we realize that paclitaxel has certain unique properties which make it actually very attractive for use as an agent for drug-coated balloon. And that is that it is by and large hydrophobic, so it can be transited on a balloon and taken for local delivery. And thereafter, it's lipophilic, so it can get attached to the endothelial or the intimal surface and get absorbed. So these are two very major advantages. But believe me, a drug-coated balloon is not just a balloon and a drug. You also have to have delivery mechanisms and you also have to have excipients which permit delivery. And that is why different companies in their process have used different things like urea or various agents have been used to actually, or even contrast medium, to actually be able to deliver paclitaxel into the tissue. Sirolimus was not thought to be a very attractive target, despite the fact that it was doing so much better. Limus analogs were doing so much better in the stent space, because they were much less hydrophobic. So therefore, there was a potential to lose a lot of drug which was going on the balloon till it reached the local site. And they were much less lipophilic, so that less of the drug would actually permeate and penetrate. Thereafter, a few years ago, once we started moving out of this background, we also had this an increased, this fear of systemic absorption of paclitaxel always remained, and therefore everybody wanted to be clear about the dose that would be applied. And I think B. Braun was the company which really worked out that they thought that 3 is kind of a perfect dose without any systemic absorption. Believe me, 95% of the paclitaxel which is put on the drug actually does not get absorbed, but it is still, the safety limit is still 10 times more. So the drug can be even 10 times more than what is actually being exposed. So there is no fear. But there was a signal, especially when we had 2 meta-analyses which were published about 5 years ago, which examined the use of drug-coated balloons, especially in the peripheral arterial disease realm. And it was found that there was an indicator that there could be increased mortality. We could not define what the mortality was, and there was immediately a large meta-analysis which countered this fear. But for about 6 to 8 months, we know how knee-jerk reaction of that we thought, oh, this is something we need to be worried about. And therefore, we started looking again at Limus analogs, especially since Limus had done so much better in the drug-eluting stent. But we had to have better means of keeping the Limus on the drug, on the balloon, and being able to deliver it to the vessel wall when needed. So very ingenious techniques have been incorporated, and the study which has been shown here uses an indigenous product from India, which actually uses some nanoparticles to deliver. Now, there have been a lot of talk, and we've been involved with some of these developments as to using various other agents to deliver these drugs, and aptamers and so on and so forth have been developed so that you could even define the penetration of the drug into the intima or the intimomedial junction, so that appropriate drugs would have appropriate benefit. But the naysayers always said that Limus, it does not have adequate lipophilicity. So is it actually doing the work? Now, the clinical data which has come has shown that, well, the results have been reasonable, and they've been reasonably comparable to those which have come from paclitaxel, and therefore there was a requirement to do a study like this, which actually gave us some real-life data on something which we could, because clinical studies or even angiographic studies are fraught with the risk that you may not be able to capture everything. But here, if you are going to harvest the animal and histologically study the iliac artery, you probably details, and that is what the authors have done here. And really, paclitaxel, because of the fear of increased, shall I say, mortality, despite the fact that B. Braun had quoted a 3 as a kind of a figure, agent which has now been introduced by Boston Scientific has gone to 2 in trying to think that with their excipient and with their drug delivery mechanism, this should be adequate and would not have the fear of having a toxic level of the drug. Now, there were drug-eluting balloons which are introduced with very high dosage. So in my lexicon, both 2 and 3 would be considered as low dose, because there were about 5 years ago some drug-coated balloons which were with 10 and 20, which had been seen to have local toxic effects, which were either where endothelial damage had happened, and there were some risks of increased thrombosis because of that. So I think the low dose works very well, and in our clinical practice, there are areas in-stent restenosis, maybe small vessel disease, maybe side branches, maybe high bleeding risk. These are places where we all like to use drug-coated balloons, and we would definitely like to have the evidence that they work, because even plain balloons work, but they should work so as to prevent restenosis and to give us good clinical results. So I think, and in 2006, when Eduardo Camenzind presented at the European Society of Cardiology World Heart Federation meeting, and he said that drug-eluting stents are a million ticking time bombs. Really, that fear is gone. But we are trying to put not only less drug, we are also trying to put much less metal. In fact, even the fear of putting extra drug, even if you do an overlapping, because we all know the length is limited and it's only one application of a drug-eluting balloon. Even if you do 2 overlapping balloons subsequently, the drug does not achieve any toxicity level. So in my lexicon, both sequent please and agent are to be considered low dose, but not just low, this is adequate dose and non-toxic dose. So that's my perspective on how to answer your question. I hope
that's Dr. Dhal sir, that's a great warm-up to what promises further to be further great scientific discussion. I will request Dr. Dhal sir now to take it forward, because we have...
So Prathap, I think we must get you on, because you know that hypersensitivity reaction to polymers and drug-eluting stents, we all had these challenges. I mentioned Eduardo Camenzind, and we all know that what the first generation drug-eluting stents went through. So I really want to know, in your practice, what do you think is going to be the relevance of the current utilization of DES versus DCB in our Indian context?
Actually, Anil actually has given an excellent overview of the drug-eluting balloon as such. But we should understand one thing. We were actually telling that Dr. Anil and me were using Taxus versus Cypher. Actually, we were comfortable with the Cypher, but the Americans were comfortable with Taxus. Why? You know, they are actually easily trackable stents. Nothing because of the stent was excellent and all. One should understand that, like Colombo told once in a Gulf Intervention Society meeting, what's the difference between Asian cardiologist and American cardiologist? He clearly told the two points. One, Asians follow science. Americans does not follow science. Number 2, Asians are actually highly skilled operators compared to the Americans. I was really shocked. The similar thing actually, we were all comfortable with the Cypher, because in a complex lesion also we could take that step. The similar picture, the drug-eluting balloon, if you come actually, the sirolimus eluting balloon first came from an Indian company called this Concept Medicals, and that is Magic Touch, which I use a lot. But I'm just telling you, my usage is actually initially restricted to the ISR, in instant restenosis. All the patients come with ISR. I don't want to put one more metal layer, and I started using Magic Touch. But it produced a reasonable result. I will not tell you that no patient came back. Nearly 20% of the patient came back again with the restenosis. There we have to use once again Magic Touch. But the point actually clinically we should understand that when you do this type of bill, we should prepare the lesion well. Prepare the lesion well. You can use by a normal balloon or a cutting balloon. Prepare the lesion well. Open the vessel very well. And you are actually taking a device inside and eluting. And what Anil is asking, which are the clinical situations where we can use. 1, I use an ISR. Number 2, in a bifurcation lesion, people actually think that actually whether we have to take a 2 stents or 1 stent technique, where a drug-eluting balloon is taken to the side branch will be a good choice, like against the provisional stenting where we use only 1 stent, especially in the complex anatomy of bifurcation lesion, especially where in the circumflex lesion, where the high restenosis happens, even with the 2 stent technique. Whatever the device, whatever the technique we use, we see the maximum restenosis in circumflex osteo. So those patients, I try to use Magic Touch. And the third thing is actually a diffuse vessel disease, where we have to use multiple stents. And Colombo has shown a data with 141 patients data. He was showing that only 2 patients came back Rest everybody was doing very well. I don't know whether it is true or not, whether he is producing a data means we should believe that. But that is actually one area where you can use multiple stents. And actually now lot of European cardiologists use a proximal stent and distal vessel is totally drug-eluting balloon. And that too, after creating a large dissection, they are telling they will wait for only 5 minutes. Then if there is no recoiling happens, then you can take away all the things and then go to. And I will tell you that none of my patients had a problem in the post-operative period. That means actually after post-angioplasty keeping in the ICU. But I have used nearly more than 700 or 800 magic touch. And that is my, I never had a problem, but 20% of the patients again came back where I have to do re-intervention in those cases. And people can tell that, okay, if you use a simple balloon, whether you could have had the same result, definitely no. But magic touch has definitely produced a result in some of the cases where I always thought that I have to send for bypass surgery.
Great. That's a great viewpoint, Prathap. And we all know, I remember a gym meeting where Professor Colombo actually did a 3.5 RCA and with a large dissection. And he said, I put in balloon and he had the conference to come out. I was kind of chairing the session and I asked him very politely, he didn't like it. I said, would you do it? Would you come back and put a stent after the case is over, or will your fellow come back and put a stent at night? You know, because to see a 3.5 proximal RCA dissected all the way and to leave it without, you know, where you think that this is going to be actually a flow limiting dissection is a challenge. And I think those are things which you cannot really overcome. So let's go to the birthday boy and ask him, Dilip, in your practice, where is it that you use drug-coated balloons? So what is your view? Prathap raised a very kind of stirred a hornet's nest, long diffuse disease. We have great challenges in treating long diffuse disease. I angiogrammed a patient yesterday that we had put in maybe a Zion stent about 13, 14 years ago. He came back with some angina. He has long diffuse disease. The stent is still patent, but the diagonal has got maybe a 70, 80%. And it's a small diagonal, but there's a long diffuse disease in the LAD. And his thallium was positive. I was very hesitant to take him on. So would you also think that 2.25 looking long diffuse vessel, diffusely diseased, would you use imaging, go in, modify the plaque with whatever cutting balloon or whatever else you want to do, and then apply a drug-coated balloon and hope for the best? Would you think you would like to do that? In your clinical practice, where do you use drug-coated balloons? Dilip.
Yeah, thanks to Ajanta for this wonderful initiative. And I think a very good summary by Dr. Dhal and Dr. Prathap said about the drug-coated balloons. And in fact, the results from drug-coated balloons are surprising all of us. So we had some fear, as Dr. Dhal told, about the meta-analysis which came in 2016. And there was an advisory from FDA in 2019 about a warning signal from paclitaxel-coated balloons and stents even. And this advisory was lifted on July 11th of 2020, I think 23 last year. So now we are pretty sure we have good evidence and good data that these all drug-coated balloons are good enough. And we have some randomized controlled trials. And that's why in ISR, DCBs are class 1 indication from ESC. And rightly pointed by Dr. Prathap that long diffuse lesions, osteal lesions, diabetic patients who are, you know, in high bleeding risk category where you don't want to prolong your dual antiplatelets. So coming to the, you know, pointed question to me, in diffuse, you know, lesions and like a 2.5 millimeter vessel, whether I would be comfortable with drug-coated balloons or not. So we have, and there is a, you know, practice changing, you know, evidences are coming in. So we have a trial called, we have a Restore SVD. That Restore SVD, they have analyzed patients with single vessel disease who had vessel diameter of less than 2.75 millimeter. And they found that this was drug-coated balloons were as effective as drug-coated stents. And one of the, you know, most striking features were enlargement of the vessel, lumen. So lumen enlargement, late lumen enlargement was one of the important findings for drug-coated balloons, which we never see in, stents. So if we have difficulty in putting stents in diffuse lesions, drug-coated balloons is a very viable option. And I tell you, with this basket small trial, all these small vessels, the results are very promising and they're positive trials. Now, in two of the trials which are coming up with paclitaxel coated balloons, like these are ICER desired trial and a transformed trial. So we are looking for these trials, and probably after these trials, guidelines will also endorse DCBs in these situations.
Great. Sarita, I just wanted to pick your brains. We all know that the mechanism for saphenous venous grafts is pretty different from what we deal in the coronaries. Do you think that there is, in certain exotic areas like STEMI or a thrombotic lesion, do you think, or say in saphenous venous grafts, would you ever end up using a drug-coated balloon? And if you would you consider using sirolimus or paclitaxel? I can't hear you.
Ma'am, you are muted.
Yeah.
So that's a difficult situation which we are looking at. An SVG graft, usually these grafts are old, very friable, and they're usually large in size. And my practice has usually been to put in stents in them. Now, if I ever DCB'd it, it would generally be a smaller size graft. It would generally be a kind of a diffuse disease graft. And when we are talking about sirolimus versus paclitaxel, we've been having a lot of discussions about these two drugs. And, the basic thing is that these are two different drugs. One is it's a macrolide antibiotic, and the other is an antineoplastic agent. And one is cytotoxic, and the other is cytostatic. And when you look at the delivery, which you yourself were mentioning, we are looking at something which penetrates directly, fast, and then we are looking at something which needs its nanospheres to deliver it. And then, so there are so many differences in these two drugs. And we have a host of studies, multitude of studies, sirolimus versus paclitaxel, and we generally find different results in a majority of them. And most of them at the end, they say that, both of them work and you can use both of them in particular situations. The slight differences in them, you would talk about which dose is best. So the low dose versus the higher dose. And if the low dose works as well, why not? Then you would talk about whether, you get a bigger luminal gain. And there's been a study which has compared that if you have a complex lesion, go ahead and use a paclitaxel eluting. And if you have a simple lesion, then use a sirolimus and it would work as well. So there's been so much work done on these two agents and these two kinds of balloons. So at the present time, what I actually think is that you can actually go in with either of these two balloons. And if it fails and this patient comes back, like somebody was mentioning that 20% of these patients come back. And if you want to reconsider a drug-coated balloon in that situation, use the other drug. But both of them work pretty well. Different studies would show you different results. A greater lumen gain with paclitaxel as compared to the sirolimus. Different mechanisms of action, different drugs, different agents, but they both work. The bottom line is that they both work, and we should go with one of them. More aggressive lesion, I would prefer paclitaxel. Less aggressive lesion, sirolimus would work as well. And if one fails, consider the other.
You've taken us back about 15 years when we used to think that if Cypher fails, put it in Taxus. If Taxus fails, put in a Cypher. But we kind of realized that even with that, the limus analogues held their sway, even if the limus analogues had failed the first time. And therefore, we started doing more imaging. We started understanding whether there were mechanical causes or biologic causes. And we started understanding how can we segment and get different phenotypes of these in-stent restenosis. So I guess there would be similar data which would need to emerge for drug-coated balloon failure. But I just wanted to ask Prathap, since he has 700 cases, whether has there been any peri-procedural MI in any of the patients in your DCB use?
No, ma'am. Actually, Anil, actually, most of the cases where I use for ISR, and few cases about the side branch, basically a bifurcation lesion and ostial circumflex in NCA. So those cases, actually, none of the cases had a peri-procedural problem. Actually, people just worry about that in major. But as actually Sarita told you, as you mentioned also, if you fail in a sirolimus, you will go for a paclitaxel. It is not the story now. In a drug-eluting stent, actually, if you fail in a normal drug-eluting stent, we can use the same type of stent again, the same thing. Actually, the available drug-eluting balloon in India was Magic Touch. Now this sequent place and the agent is coming up. But I don't know whether it is actually data telling that Magic Touch is worse than the other two. But for our practice, and many people who use Magic Touch in India have an excellent result. And there is no peri-procedural problems I came across. But I'm just telling that may be an incident where you may be watchful of doing these things. And most of the cases where I use a drug-eluting balloon, where I use a cutting balloon rather than a normal balloon.
So do you always do imaging to ascertain your results, or you can get away without imaging?
Yes,
so you're
actually,
using cutting balloon.
Anil, actually, any ISR, I definitely use an imaging. But most of the cases of bifurcation and all, we don't do imaging routinely. In those cases, cutting balloon is one area where always, whenever I use a drug-eluting balloon, I use a cutting balloon and then use a drug-eluting balloon. Probably that may be one of the reasons that I may not get many peri-procedural problems.
ISR, we don't have a challenge. We know that we have enough data with drug-coated balloons. We also don't have a challenge with small vessels because the Picoletto itself had shown excellent results, and we don't have a choice. You have a 2 millimeter vessel. You can't put a 40 millimeter stent in a 2 millimeter vessel and hope for it to last. There are inherent advantages of using a drug-coated balloon. Same thing, if your patient has high bleeding risk and you want to avoid a stent, definitely I think that is a situation, peri-procedure, peri-operative, peri-transplant. You have a patient, you want to get away without doing very long DAPT. Those are not challenges. Even side branches are probably not as major challenges. But there are labs in the world. There is Simon Eccleshall, whose lab says that 90% of the PCI done in that lab uses only drug-coated balloon. All STEMI get only an imaging and thrombosuction, thromboaspiration, and a drug-coated balloon. Now, that is probably stretching our imagination a little much. So I want to take your perspective on it. That's why I asked vein graft, because it's unusual. Because we understand, we are all scared, and especially to some extent, we interventionists have been spoiled by the stent, especially the drug-coated stents, because the images look so great. Once you angiographically, you find that you're looking absolutely perfect. Then by all our imaging criteria, we look at apposition, we look at distal dissection, we look, okay, we've done a good job, and we calculate whatever is the MSA, and we are happy with it. But what about using in de novo lesions, in STEMI, not in small vessel, not in in-stent restenosis? What would be your thought or process on use of drug-coated balloon, especially when these kind of studies have been reported? Prathap?
Anil, actually, there are 3 areas only where I use drug-eluting balloon. I clearly told you. One, in ISR. Second is actually diffuse small vessel disease, and the situation is bifurcation. Initially, I was only in LAD diagonal and sarcoium and all. Now I started in the late time, actually the recent time I started using for sarcostium, because actually that area I was very much worried, because many patients after LMCS tending perfect result in imaging, they come back. So I was thinking that why don't I use drug-eluting balloon in the first instance? If at all they come back, I can try a stent second time. So that is the area where now I started these things. But like Colombo showing those things actually still, I will not be able to use that. Because
Sarita, what about your...
It is difficult.
Fully agree. My experience, see, in India, the scenario is such that, you know, you don't want to come back in the middle of the night. So if I have a proximal vessel, a big enough sized vessel, I wouldn't want to DCB that. I generally use it in smaller vessels, distal vessels. When I'm doing a bifurcation and I want to get away with one stent, ostial circ is another very good indication for it. So it works. But the question is that we don't normally use it for other indications as of now, and we don't have a lot of data indicating it for those other indications right now. I think I would like to wait for them to see it, because I've had instances in which I've used a DCB, seen a dissection, and while I'm working on the other vessel, I've seen that vessel starting to shut down, and I've had to come in and put a stent there. So I would still be skeptical about the other situations.
Good. You know, that's always good to be. Discretion is the better part of valor. Dilip, what about you? Do you think you would be open to using some of these other indications?
In fact, I had the same view as what Dr. Sarita and Dr. Prathap told. But surprising is the fact that when I was reviewing for this particular journal club, I was really kind of astonished with the kind of evidence DCBs have generated in last 3-4 years. And these were all not observational or registries. Although we have a very large registry, there were some good randomized controlled data as well. And that is where the promise lies. Like why some of the labs are going for 90% DCBs, because they have got some very real good data. That's what I enumerated a little while back, that a basketball trial, restore trial, and multiple good RCTs as well. And there is no surprise that our what we are used to do for last 20 years, seeing disease and fixing it with stents might change. And that's what this journal club has done for me. And I am now aware about the results and the evidence. And surprisingly, the 1 year data, 1 year after the DCBs versus doubling stents, in fact, DCBs are on better side numerically, although there are no difference, but they are numerically better side in the, in the MI, incidences, MACE incidences, TLRs, and that is where. So till now, my practice remains the same as what we have been discussing. But after this journal club, I feel that I will take cognizance of this data, which is all there. And that is why some of the European centers are so aggressive about that. We'll be taking our, practice to somewhat little, leading towards DCPs as well.
Great.
I think, Anil, can I have one comment?
Yeah, please.
Because in the last India Live, there was a live case shown from, I think from Germany or some other country. They were using they wanted to use a drug-eluting balloon. There was a proximal LED lesion, which actually not opened up very well. They just, with a lot of calcium, they tried to open with some cutting balloon, nothing effective. That fellow just put a drug-eluting balloon and then told that excellent result, because 3 Americans were chairing. I was also in the chair. They told excellent result. I don't think it was excellent result, but I was repeatedly telling, I don't think it is a good result. Then Ajay told Prathap only 20%. Actually, I don't think these people actually little overusing. The similar thing actually, when you look at the Impella usage in many of the cases, which I felt that it is definitely for the marketing purpose. And that is actually one area. If the clinically relevant thing in India, it is a totally different thing, where we should actually having an excellent data to produce that. And I think that we should. And number 2, you told STEMI situation. There is actually plaque erosion. There is no need of a stent. That is actually erosion trial clearly showed that. So you don't require a stent at all. Where you use a magic touch or whether you use an agent or a sequent please, what is the difference? No difference, because that will not produce. And about this venous graft, I still have a problem, because venous graft is actually atherosclerotic or not. That is actually, again, whether drug-eluting balloon can do anything or not. I personally feel that that is one area where we should actually have a real thought process. 2 areas you asked to Sarita. One is the venous graft, second is a STEMI. STEMI means many erosion, actually, plaque erosion, nothing is required. So whether it is really the balloon is
Sarita
producing-
wants to say something. Sarita wants to say something, and I'm getting nudged because you're running out of time. The discussion is getting exciting. But life has turned a full circle. Don't forget that just last week we have had the PREVENT trial being released. Yes, Sarita, please go ahead.
So I was saying that, in a country like ours, the patients find it difficult to come for even one procedure. And if a patient comes in for one procedure in a country like India, and he has a proximal LED lesion, a large vessel, young gentleman, I would put in a stent any day.
No
I
doubt.
wouldn't DCB him. The second thing is that in a country like ours, you've done a procedure, you're liable for it. If it shuts down at 2 o'clock at night, I'm going to be running back to open that vessel and put in another stent. And the third thing is the cost is literally the same. So in a proximal vessel, we don't have enough data to tell us that DCB the proximal vessel. I wouldn't do it. And second thing, when you said vein graft, you said huge amount of thrombus. My DCB is not going to deal with that situation. I need to reestablish flow. And I think I would still need a stent in that situation with that huge amount of thrombus after I've given, everything that I could.
And just to add to what Prathap had said about osteal circumflex, I think the preparation of the osteal circumflex is probably much more important than whether you choose a stent or you choose a drug-coated balloon. And that's where we all have to exert a little more and do that optimally and see how it takes us. But life really turns a full circle. From the time that we used to put stents in everything and we were very happy, then we found all the problems with stents, then we came drug-eluting stents, then we tried to take away that, we had the BVS, the BVS went away, and now we are back with DCB, and now we have the PREVENT trial, which is actually telling us do preventive angioplasty and it works. So everybody
For everybody, angioplasty.
They would be a little confused. No, somebody who owns a hospital chain like Prathap would probably be very happy with the results of a PREVENT trial because everybody who comes in goes back with an angioplasty.
I should actually tell I don't do that.
I know you don't do that.
I'm
just joking.
Actually, one of the most important things is circumflex ostium. Like Kirtipanemi is telling, okay, you use a cutting balloon of 3 millimeter. You are actually not getting an adequate result. Take a 3.5 cutting balloon. Actually, then you take an OPN balloon. How many people in India can actually
No.
And
Let's talk about practical angioplasty.
Finally, we will be, our colleagues and technician will tell, sir, the cost you told is this much. How many balloons you can take? You finish it off. You will be happy with the 6 millimeter square sarcostium and don't go for a higher measurement. They may come back. That is actually one area I'm always worried.
Chalo, I think we've had a lot of very exciting discussion on DCB. It is a very contentious topic. And we must move on to the second paper because we must do some justice to that as well. And we have two very large volume, large axis, large bore operators here, Sarita and Dilip, who have tremendous amounts of experience with using large bore axis, as well with whether by using lots of Impella like Sarita does or lots of TAVI, which they've both been doing. So the Manta is actually quite a good device, but the trial which has been shown here is to substantiate the one ProGlide hypothesis with using either a second ProGlide, either an angioseal, a second ProGlide, or a Manta as your finishing agent. So first, before we go to that, I would like to ask Dilip, are you still using for large bore access, are you using 2 ProGlides or using 1 ProGlide as a default strategy?
Yes, I think in my practice, I decide on these 2 strategies depending on the vessel size. If the vessel size is more than 6, I have no hesitation in taking 2 ProGlides because they are always better. And if the vessel size is less than 6, I am going with 1 ProGlide, and if additionally needed, I go for an angioseal.
What about you, Sarita?
So my practice is I generally go in with 2 ProGlide. And after that, if it's required, usually 2 ProGlide always work well. And only after that, if it fails to close, then do I take an angioseal, or you can also take an obtura. So you can take either of the 2. The Manta per se is not available in India.
I know.
It will be launched at the end of this month. And we don't have it as yet in India. So none
No,
of us.
but I think that's why I deviated from the paper itself, because we don't have MANTA. So really what our younger colleagues need to know is that should they go with a 1 Pro glide to start with as a default strategy, or 2 Pro glides. In fact, if you're using 2 Pro glide as your default approach, this paper becomes ineffective because it actually does not have a study arm where 2 Pro glides have been used and then you are looking for anything else. So I think really you've answered that very well, Dilip, that in your practice, most of the time you are using, in small vessels, you're using 1, but majority of the time you end up using 2 Pro glides. Sarita says she's also using 2 Pro glides. Well, we've been using 1 Pro glide plus minus 1 angioceal. We've been trying to be a little less aggressive with using more Pro glides in our limited practice. And that is because we thought we would be able to get away with it. And the second, once we try with an angioceal, our choice is largely we use 1 Pro glide, and then we have to decide whether the second one has to be a Pro glide or has to be an angioceal. And that is where the relevance of this paper comes, because they've got a third choice about using a MANTA. And do you think, how much do you think is going to be the relevance of MANTA? We were all hoping that MANTA would be used as a single agent. And that would be a great game changer. Without a Pro glide, go ahead and just put a collagen plug and come out. And that may be, which may make things very easy. But what do you think is your expectation? I'll start with Dilip. What do you think is your expectation?
Yes, sir. I think this intervention issue has 2 articles on MANTA device. One is MANTA as bailout strategy. So at this point, I must clarify to all the viewers that MANTA is never endorsed as a primary strategy, because the initial results from MANTA, which we all think that just like an angioceal, if we go with a large bore access, if you deploy MANTA, come in, that's fine, and it's a quick job, not a 4 or 5 step of Pro glide. And there is also no fear of Pro glide getting broken and snapped off. So, but the 2 randomized controlled trials like Choice Closer and MASH trial, they clearly show that MANTA gives you more adverse events, more adverse, peripheral vascular, events. And then there is no role of MANTA as a primary strategy. So MANTA as a bailout strategy, because many times, in spite of going with ultrasound kind of puncture, looking exactly at the bifurcation, the distribution of the calcium, taking into account everything, best possible, vessel access to Pro glides. Many times your Pro glides can be snapped off, and then you are left with nothing, and only wire. And then you have only one option of either you put a cover stent, or you ask your surgical colleague to come in, and while he is coming in, you have to balloon tamponade the vessel, because you don't have other options. Once the Pro glide wire is broken off, especially if you have taken 1. If you have taken 2, still there is some hope that one is working and other angioceal you can do that. So MANTA as bailout strategy, 4.4% of the cases, the initial vascular strategy didn't work in the first, the paper which is there in the intervention. And there it showed that MANTA as a bailout strategy was reasonably, effective in 75% of cases and safe as well in 85% of the situation. So this was one study. And in second study, what they have shown is what Dr. Deepak initially, enumerated and showed the slides, multi-close algorithm, where they put 1 or 2 Pro glides, and then while coming out, they put 6 to 8 French sheet, and then they saw that if there is a very huge, bleeding coming in, they went with MANTA. That was only few cases, only 12, 13 cases. And rest of the cases, if the extravasation was not huge, they gave injection through the same sheath. And if it was minor, they left it over and they just pressed it. If it was little more, then they put a, angioceal. So at this moment, we have a lot of clarity that MANTA is not a primary kind of option. It's always a bailout option, and it can work.
Sarita, your comments?
So both these papers are actually very interesting. First of all, when we say large bore access, we have to be very clear about a couple of things. One is the preparation that goes into it. So your preparation right from the time that you do the CT and you look at the vessel, what's the tortuosity of the vessel? Is there any calcification at your access site? What is the caliber of the vessel? All those things which go into planning a large bore access, one. Second is that generally people would prefer an ultrasound guided access. Also, if you look at the paper, they did a micropuncture access. The third thing is that the operator's choice and the operator's experience really matters. We know for people who've been using 2 perclos upfront, we know that many a time one of those percloses malfunctions. So it's many a time it gets into a messy procedure. And one of them, like Dr. Dilip was also saying, if it malfunctions, you're stuck. You need to put in a plug-based device. My personal preference is I start with suture-based devices. I upgrade. If we're not having closure, then we put in a plug-based device. And MANTA also requires a lot of experience. If you will see that all of the 3 centers in which this trial was done, they had a lot of experience with using MANTA. MANTA comes in 2 sizes, 14 French and 18 French. We haven't used it as yet, but it also requires experience as to how to do it, because there are 2 things. On one side, you can end up occluding the vessel also. On the other side, you can end up putting it superficially also. In both the instances, you would run into a problem. 14 patients did have failure to close with MANTA. Also, a very important thing when you're doing a large bore access is to always have a contralateral access ready for your balloon tamponating or for your covered stent implantation. And of course, always having a surgical colleague on call. So I think practices differ also according to the experiences of the operator. Second, what is available in your lab, whether you only have suture-based or you have collagen-based or you have both. Third is the experience of the operator and what he's using. But this study was interesting because they looked at the extravasation of mild, moderate, and severe and used MANTA as a bailout in severe extravasation cases.
Great. I think that's an awesome summary. And I think we are also getting nudged that we had planned this for 1 hour and we've already made 1 hour and 10 minutes. So I do thank all the expert speakers here.